everybody. My name is Mirvat Alasnag, and I'm one of the social media editors for CCI Journal. We're starting a new project here, and we're trying to bring to you a Journal Club roundtable. Now, as you all know, CCI Journal has been one of the first journals that actually accommodated case reports. And at the end of the day, this is an interventional community that is interested in procedures, procedural tips and tricks, techniques, and new devices. With us today is Dr. Morton Kern, who is going to be leading this project with us, alongside us, and of course our editor-in-chief, Stephen Bailey. So I'm going to turn over to Dr. Bailey to talk to us a little bit more about today's program.
Well, thank you, Mirvat. As you indicate, this is a new initiative, one we're very excited about. We do know that case reports often spark some of the greatest interest because they highlight specific needs in interventional cardiology, unique approaches, and hopefully educate us on how we might handle that next approach. And so as we're doing these, we wanted to take a moment to do more than simply provide them in print, but to enlarge upon them a little bit and talk about what we have learned, what we still can learn, and how we can apply this. And we're excited to have Morton Kern from sunny Irvine, California, who is joining us as the moderator-in-chief for this series. And our first session actually hails from Texas. It's an excellent group that has recently reported on their experience in an individual case with ventriculo-atrial uncoupling with an Impella-assisted HVAD from the University of Texas in Houston. And we're excited to welcome Dr. Jumean and Dr. Salas for this discussion. We hope you enjoy it. We know it's going to be entertaining. And with that, I'm going to turn over the microphone to Dr. Kern to help moderate this discussion.
Good. Well, hello, everybody. And I think this discussion of this fascinating case will be worthwhile. I just would like to start with an introduction with Dr. Jumean and Dr. Salas. In a couple of words, could you tell us what you're doing and where you are? And then we'll get into the case.
Thank you for having us. I'm Marwan Jumean. I'm an associate professor at UT Health in Houston. I've been here for about 10 years or so. I'm an interventional and transplant cardiologist, and I'm here with my colleague, Dr. Salas.
Yeah, I'm a cardiothoracic surgeon and also do heart failure surgery with the team. Same amount of years and associate professor too.
Wonderful. Well, the hemodynamics you showed us in your case are fascinating. So I'm just going to ask you, could you give us the summarize the case for me and give us the important findings, and then we'll get into some of the details. We only have 10 minutes, so I'm going to hustle us through this as best I can.
I'll be quick. So this is a 51-year-old patient with non-ischemic cardiomyopathy and poorly controlled diabetes. Came into our center in a low flow state. His hemodynamics were very deranged. His filling pressures were relatively okay, but his cardiac index was 1.3. He was supported with PMCS with a balloon pump and transitioned to an HVAD. Post HVAD, he was doing okay. His PA pressures came down and PVR came down, allowing him to be listed for transplant on the UNIS transplant list. Unfortunately, 2 years post, he developed progressive AI, and with the progressive AI, there was evidence of pulmonary hypertension again. His PA pressures were in the 50s over 20s. His wedge pressure was elevated. And at that point, we were deciding what the best next step of action to care for this patient. Keeping him on the transplant list with a relatively high PVR may be problematic post-transplant. Doing an LVAD exchange would add complexity to his care in terms of reduced sternotomy and so on and so forth. And biting the bullet and assuming that his PVR is going to be okay also poses risks post-transplant. Doing off-label procedures for the valve may be problematic for the AI. So at that point, we had a team discussion and decided on what we decided in this case.
In addition, taking to LVAD and reduced sternotomy and also adding the aortic valve replacement, it will increase the pump time and the risk for right ventricular failure in this young patient that was already listed So we were trying to find a better solution to get him to the point that he can get a transplant.
Okay, one point for clarification is HVAD is what device? That's an external support?
No, intracorporeal hardware is the old hardware that was taken out of the market a couple of years ago.
Okay.
So he has a durable LVAD, and then developed AI, and then the pulmonary pressures were elevated. So there was this discussion if this is a truly pulmonary hypertension or this is related with the unloading for the concomitant aortic insufficiency, and then it was safe to take this patient straight to the transplant, or having the risk to have a primary graft dysfunction or right ventricular failure due to elevated pulmonary pressures.
Okay. Pulmonary hypertension in a failing left ventricle that's already got an LVAD in place, and it's failing because of aortic valve insufficiency. The dilemma is for you to take us through your thought process on how you would address this.
The first step is looking at the echocardiogram. There is evidence of aortic insufficiency. That typically does not trigger anything beyond just looking at it unless the patient is symptomatic. So this patient was somewhat symptomatic. So the next step is let's assess this with invasive hemodynamics so that we can get an understanding of what's happening to him from a hemodynamic perspective. So doing a right heart cath demonstrated that there is a few things. Number one, there is elevated PA pressures. The PA pressure went from 30s to the 50s with an elevated PVR. This was driven as well by an elevated pulmonary capillary wedge pressure. But what's interesting in this is that the hemodynamics also show that the RV was not doing as well, as evident by the RA pressure of 15 with a wedge pressure of 22. And what happened with increasing the pump speed to see if we can unload the ventricle with a higher LVAD pump speed is that we were able to bring the pulmonary capillary wedge pressure down. However, the PA pressure didn't go down as much as we would like it to go, maintaining a relatively higher PVR than what we'd like. And what's more interesting is that his RA pressure did not change. And this reverse ratio where the RA pressure is 15 with a wedge pressure of 11, if we keep it a longer duration, can potentially lead to post-LVAD RV failure, which is something that may complicate the picture further for us and can be detrimental to the patient. So at that point, we kept the patient on the lower pump speed and said we need to unload that ventricle in a different fashion. Hence, the Impella-HVAD came into place.
Okay, and you picked the 5.5 because of what reason?
Well, there is not a lot of resources with mechanical circulatory support. What we have found by some experience that if you have aortic insufficiency and the pump is able to deliver more of the flow that is coming back to the ventricle, then you can have a successful story. And that was the principle that we were using. Since this is a transvalvular device, if you're able to push blood out of the ventricle more than you can, the more of the flow of the blood that is going to come back to the ventricle, then you can reduce the AI, and hence you can see if they have some impact on the pulmonary pressures in this patient.
No, the other thing is the Impella-HVAD has the advantage not just of more forward flow compared to the CP is the ability to ambulate the patient, the ability to unload the patient a little bit more for a longer duration of time than Impella CP, which may cause some issues down the line after 48 hours of support.
Okay, so that's because of the site of insertion or because of the device itself?
Device itself.
Okay. Very good.
We call this device have 4 pillars. One is able to provide similar flow than the durable LVAD in normal condition. The second pillar, if you come from upper body access, it will allow, as he said, rehabilitation, ambulation. The third pillar for us is it has the less hemolytic. It's called modified hemolytic index, so it can provide less hemolysis even than the heart-lung machine. Those are the main issues that we see with this pump for this particular case.
Okay, 1 second. So let me ask, is the hemolysis less with the 5.5 than it is with the CP?
It is. It
Okay,
is, and
and
there are
is that
models.
because of the, go ahead, tell us why.
First, because it's a bigger motor. So the RPMs that the pump has to generate to provide flow are less than the other pumps. In addition, when they have done this experimentally in some computerized models, it has shown that it's lower than the other ones.
Two questions. Let me ask Mirvat. Mirvat, what should be our end game here for this patient with AI now supported by a 5.5 Impella plus the durable HVAD? Where should we be going with this person?
I think at some point we're going to need to discuss whether he is going to be upgraded on a transplant list, or whether we're talking about, this is not a bridge to transplant, but rather a destination therapy. And I think those are the kind of questions that at this point we're trying to answer. He is 51 years old, and it appears from their presentation that he is probably a good candidate for transplant. Maybe list him.
So, Dr. Jumean Salas, where's your goal here? Where are you going with this patient?
Is to prove that the pulmonary pressures are acceptable for this patient to go to a safe transplant.
Okay, excellent. That's exactly. And so I think tell us what happened to his PA pressures. You did already, but tell us again. And then I want you to just recap for us the beauty and value of the pressure volume loops you showed us in figure, what is that, figure 5. It's really striking. So first question, PA pressure responses.
Yeah, so the PA pressure responded nicely. The PA pressure went down to 37 systolic over 12, with allowing us to show that we're not only just unloading the left ventricle, but also effectively reducing the PA pressures without impacting RV function. His RA pressure went down to 10, and subsequently in the 12 to 24 hours in the ICU stay after that actually went down even further. So that in by itself is reassuring for us that it's safe to proceed to transplant listing. And as Mirvat said, maybe upgrading at that point, we upgraded his status because of VAD with a complication, allowing us to transplant him sooner. The second thing is, the second thing is looking at the question about the PV loop. It's very interesting. At a lower Impella support, we were able to demonstrate that there is no uncoupling between the AO and the LV tracing. But at a higher P level, we're able to bring the LV pressure down, allowing us to maintain aortic pressure. Such separation suggests that we're able to unload consistent with the models that Dan Berkoff showed in his PV loops as well.
There we go. So this is the figure that I was very intrigued with, because it's really excellent. And this is the Impella because of this triangular shaped PV loop design, as it's continuously unloading from the upstroke, which is this isovolumetric contraction and then the ejection. So tell us about the uncoupling. The uncoupling comes here on the right side, where we see LV pressure and aortic pressure. And we've in interventional procedures where we have an Impella in and we worry that we're going to occlude the coronary producing ischemia, stop LV function, and we want to maintain arterial perfusion, we rarely see uncoupling like this. Occasionally we might see something that looks like figure B, but I don't think we've seen much that looks like figure C. And of course, D is out of the question. The guy'd be a little off the table. So how should we interpret these A, B, C, and D pressure volume loops in terms of ability to be transplanted, if that's what we're doing?
So when it comes to LVAD therapy, with an LVAD, you're able to get to D. That's the goal, is to be able to reduce LV pressure significantly while maintaining, a central aortic pressure. When you have LVAD dysfunction, if we look at the tracings from figure 1 in this graph for this specific patient, You can see in figure 1B that there was no uncoupling. The tracing looks exactly like what's shown here in figure A, which tells you that you're not unloading the ventricle with an LVAD. But by increasing the pump speed on the Impella, you're able to shift the curve leftward and downward on that PV loop, allowing the unloading, the adequate unloading of the left ventricle, which is what we want to do. And by doing so, the beneficial effects of unloading, not just with myocardial ischemia in the cath lab, but for this specific patient, bring the PA pressures down, allowing him to move to the next step with a transplant.
Yes, what an excellent case. I think that's good. So I think we're a little at the almost end of our 10-minute block. And Mirvat, I want to get your view, and Steve, if you have something you want to add in here at the end, let's hear a couple of thoughts. I'm impressed very much. Beautiful.
Absolutely. And just, a practical point for folks who are starting to treat heart failure patients and implant more of these devices. What kind of an algorithm do you have for unloading at this point in time in your units?
When it comes to LVAD therapy, with the shift towards implanting HeartMate 3s, the technology has somewhat changed. The classic teaching of a third of patients will develop moderate severe AI at 3 years or 40% at 4 years. In the era of HeartMate 2s and HVAD, maybe a little bit different. That's number one. The impact of long-term PMCS support with an Impella-5.5, for example, as a bridge to an LVAD, and that in itself on the aortic valve and its detrimental issues on the aortic valve itself may unfold in the next year or two. We'll maybe see more of that. The technologies for treating AI percutaneously is also evolving outside of the LVAD, and if we can use that in LVAD management. But the first step is always when you have clinical suspicion of inadequate unloading, you couple that with non-invasive imaging, you couple that with invasive hemodynamics, and then you try to understand why this is happening, and then use your tools that you have, and sometimes thinking outside the box by putting hats of the surgeons, the interventionalists, the heart failure physicians, and what to do next. So it's hard for me to tell you this is our algorithm, because my algorithm probably is going to change in 2 months with newer technologies moving forward. But again, at the end of this is a group of patients that we have to be all invested in caring for them and sometimes thinking outside the box.
And this is all a heart team approach. That's what a cardiologist and a surgeon are sitting together here. I think this a beautiful model that we have here in the University of Houston, that we truly put our head together and make the best decision that we think with the best evidence for the patient.
Yeah, no, I think it's a great demonstration. As we heard, there really are 3 issues here. One was the aortic insufficiency and the evolving approach to that. The second is ventricular function over time with durable VADs. And lastly is the continued importance of right heart function or dysfunction. And, evaluating all of those was done so carefully and so thoughtfully to arrive at the right decision for this patient. Congratulations.
Wonderful case. Mirvat, the very, very last word.
Well, thank you, gentlemen. Really a very educational case, and I'm going to tell our viewers, stay tuned. We do have more cases lined up for you.